Hello, everyone. Welcome to this BOMSS webinar, educational webinar. Today is 22nd of February, and I'll be chairing the session today. I'm Chetan Parmar. I'm one of the bariatric consultants in Whittington Hospital, London. And without any ado, I would like to invite an exceptional speaker today, Professor Alex Miras. He is a professor of medicine in Ulster University in Northern Ireland. He is also a visiting professor in Imperial College, and he's widely published and academically known all around. So without wasting any time, Professor Alex Miras, welcome, and thank you for agreeing to do this talk.
Chetan, thank you very much for the invitation. I'm glad to be giving this talk, and I'm pleased that people are joining, even if it is late in the evening. So there we are. I hope you can see my slides. So these are my disclosures. What I will be talking about today are specifically our work on the effects of bariatric surgery on the polycystic ovarian syndrome, and the work that we have been doing over the last 3 years actually on this. So we do know that obesity affects female fertility in a number of ways. We have got this type of pathology, which very much resembles what we see in men with hypogonadotrophic hypogonadism. So pituitary dysfunction due to obesity that leads to problems with fertility. But we also have got this angle here, insulin resistance and hyperinsulinemia, and its effects on a smaller cohort of women that are also suffering from polycystic ovarian syndrome. This is a very a schematic representation of the key components of the polycystic ovarian syndrome pathology, in which what we are seeing is that one of the major drivers is hyperandrogenism, which causes the ovulatory dysfunction, and that means that the ovaries are producing follicles that do not actually mature. As a result, these women can have irregular periods or no periods whatsoever, and clearly that can affect their fertility potential. But what is key, and this is where I came from in the field, is the concept of hyperinsulinemia and insulin resistance that is associated with obesity that is fueling a lot of these pathologies. So I'm not a reproductive endocrinologist. I'm coming from this the metabolic, with my metabolic and obesity hat on. You will know that there are numerous criteria on how to diagnose polycystic ovarian syndrome. And I must tell you, I cannot remember what each of them specifically say, but I think what is important to remember are what are the key parameters that they more commonly involve, which are oligomenorrhea or amenorrhea that we've just mentioned, so either few or no periods whatsoever. Clinical or biochemical hyperandrogenism, which is usually expressed as the free androgen index, which is a measure of the free testosterone floating around and having its effects on the end organ, which is the ovary, and also polycystic ovarian morphology on ultrasonography. But I think that even though you, as perhaps in the surgical community, you may not be going into specific details about the polycystic ovarian syndrome pathology that you see in the woman in front of you, I think you will agree that it remains a very heterogeneous condition. And I think the criteria for diagnosing it also reflect that. Now, just to say that we have also recently conducted a meta-analysis of the best available evidence on the effects of insulin sensitizers on polycystic ovarian syndrome, and we incorporated studies that include metformin, some with GLP-1 receptor agonists, pioglitazone, etc., that have been used in the past more for the treatment of polycystic ovarian syndrome. And we found that overall, either they had a very, very small effect on insulin sensitization. They had a small effect on the symptoms that actually these women are suffering from, that have and suffer from, some of them being, the worst ones being hirsutism and acne of facial appearance. And the other thing that I thought was very interesting was that it was very difficult to find, in fact, we couldn't find any randomized controlled clinical trials that looked at hard outcomes of ovulation and fertility, so pregnancy. So that is more in the medical literature. And I think that based on my experience, I consider women who have polycystic ovarian syndrome to be different compared to women with the same body mass index that do not have the polycystic ovarian syndrome. And overall, in my experience, I find that weight loss is very difficult in this cohort of women. And that's not because they're doing anything wrong themselves. It's because I think, again, as always, they're battling with their own physiology. This is a nice small study from Steve Robinson and Steve Franks done at Imperial back in 1992. And what they did in that study is that they studied women with polycystic ovarian syndrome and women without. The women with polycystic ovarian syndrome are in the empty boxes here. And they measured energy expenditure, they measured diet-induced thermogenesis after a meal. And what you'll see very nicely here is that these women basically burn fewer calories after they have eaten, which is not helping with any of their weight loss efforts, of course, and it also correlates with their metabolic dysfunction as well. So this is a resistant group of patients when it comes to any treatment, I would say. And again, going back to the endocrine clinics, those symptoms that they're suffering from can be really resistant to any of the treatments that we are offering, hormonal ones or lifestyle modification ones. Doesn't mean that they don't work, but the effect size is small. So in 2018, I saw and I read a very large document, which were the guidelines, the international guidelines for the treatment of polycystic ovarian syndrome, that were driven mostly from Australia. And I was very surprised to see that the phrasing that they used, I think, was a bit too conservative. They were saying that bariatric surgery, and I've got a quote here, should be considered as an experimental therapy in women with polycystic ovarian syndrome, with a risk to benefit ratio too uncertain to advocate this as a fertility therapy. And I think they have a point, because we did not have any RCTs at the time. On the other hand, again, I did feel that it was a bit conservative, because we've got some very nice data from non-randomized trials that show the pretty impressive effects of surgery. This is just an example where we're showing reductions in hirsutism after, I think this was a gastric bypass study, reductions in free testosterone. So not only hormonal changes, but also here hirsutism changes, which is what bothered these women after weight loss with bariatric surgery. So not only the positive sign, but also a pretty decent effect size. And this is also reflected in the most recent meta-analysis that I could find from last year, in which you'll see in these forest plots that the effect of surgery on abnormal menstruation, hirsutism, total testosterone, and free testosterone not only are there, but they are very substantial in terms of clinical significance. But in order to change practice and in order to change guidelines, we need RCTs, and ideally we need RCTs with hard outcomes. And this is what we have been doing for the last 3 years. We call this study the BAMBINI trial, so bariatric surgery versus best medical care for women with obesity and polycystic ovarian syndrome. This was a study that took place in 2 sites, London and Coventry, with Vinod Menon and Harpal Randiva. And we recruited 80 women on a 1-to-1 randomization basis, 40 randomized to lifestyle intervention, 40 randomized to sleeve gastrectomy. We only did sleeves in these women. And the follow-up was 12 months. The eligibility criteria were obesity, BMI over 35, evidence and diagnosis of polycystic ovarian syndrome, and at less than 8 menses in the previous year, less than 8 periods in the 12 months before. This was a self-reported eligibility criterion. And in order to try and make this as robust as possible, the primary outcome was not reported menses, or it was not just body mass index or measurement of hormones, but it was actual biochemical evidence of ovulation, which is a pain to do, and I will explain why. And we've got, of course, as always, many secondary outcomes that included some of the things that I have mentioned, so metabolic outcomes, insulin sensitivity, anthropometric data, etc. So this is a diagram of the study. And these women were, I would say, treated pretty much as any woman who is eligible for bariatric surgery would be in the National Health Service. They underwent standard assessments, and after that they were randomized either to a sleeve gastrectomy or to lifestyle modification. They were followed up for 12 months. And here is the thing that made the study pretty challenging was we asked these women to have a weekly blood test for 52 weeks. They had to come once a week to have a blood test for serum progesterone, because we wanted to see whether we could capture this rise in progesterone that is definitive objective evidence of ovulation. In terms of what we offered in the lifestyle modification group, that is really important to clarify now. So they had a 12-month tier 3-like course with a dietitian, psychology as necessary. The intensity was actually not bad. They were seen every 2 weeks in the first 6 months of the study in group or 1-to-1, and beyond the 6 months they were seen once a month. So not a bad not bad support. They were also offered orlistat or metformin, because these are the medications that are available for this cohort of women in the NHS. At the time when we started the study, medications like liraglutide, etc., were not part of standard of care, so they were not included. I'm showing you some unpublished results here. The last patient last visit is expected very soon, and so hopefully we'll be sharing the final results from the study in the next few months. But I think these are pretty indicative, what I'm showing you here. So body mass indices of about mid-40s, HOMA-IR, a measurement of insulin resistance of 4 or so, which is just pretty high. High free androgen index, and you'll see that these women were truly oligomenorrheic. So they had 3 to 4, a median of 3 to 4 cycles in the 12 months before they entered the study. In terms of the race, they were in their early 30s. And these are the results that we have so far. This is weight loss at 12 months. Unsurprisingly, women in the surgical group lost approximately 30% or so of their body weight, and the women in the medical group pretty much maintained the weight that they had at the beginning. So we would have liked to have seen a little bit more weight loss, of course. But I think again that demonstrates the resistance, probably the physiological resistance that we do encounter when treating with these women, even though they were treated very well. They were treated reasonably, I would say, intensively. I wouldn't say very intensively, and I will explain that in the question session, perhaps. Unsurprisingly, these are the improvements that we've seen in metabolic parameters. So we this nice reduction in the area under the curve on the oral glucose tolerance test. This is at 12 months, the data that I'm showing you on a smaller cohort of women, even though all the women had oral glucose tolerance test at 0, 6, and 12 months. So you're seeing this very nice reduction in glucose. And even though these women did not have diabetes, but they might have had pre-diabetes, you see no significant changes in their HbA1c in the medical group, but a statistically significant reduction in the surgical group, again demonstrating the metabolic improvements. When it comes to other hormonal measurements, you will see nice reductions in both the total testosterone here. Only in the surgical group, there was a tendency, interestingly enough, for a small reduction in the medical group, even though they did not lose any weight. There was no change in the free androgen index in the medical group, but a pretty nice reduction, I would say, here in the surgical group. And despite this healthier metabolic and reproductive hormone changes, we did not see, even after surgery, a reduction in the Hirschism score, the Ferryman-Gallwey score, in these women, either in the medical or in the surgical group, which I was surprised about. And this is the main and key slide of the results. This is the number of ovulatory cycles that these women had in 12 months. And you will see that in the surgical group had approximately a median of 7 cycles, as opposed to 1 or 2 cycles with the medical care group. This is a median, and this is all, as I was saying, based on objective biochemical evidence of ovulation, not just reported menses. So a very large, I would say, effect size on an outcome that is likely to matter in these women when they are pursuing fertility in the future. Adverse events, not much in the medical care group. In the surgical group, there were a couple of women that struggled a little bit with vomiting and nausea and poor oral intake after the sleeve gastrectomy, but that generally settled. Some wound infections. I don't think that is too surprising. This hypoalbuminemia that you are seeing here was truly there, but it was temporary, it was transient, and there was an equal number of pregnancies in both groups. We had to put pregnancy as an adverse event because it was not the intention of the study, and certainly not in the first 12 months after surgery. But even though that happened, these women have remained very well, have done very well. In terms of the contraception advice that we gave them, it was to use non-hormonal contraception, because clearly that would affect all of our measurements. So barrier methods, abstinence, etc. So overall, a pretty good safety profile of surgery. So I'll finish off here, and I will say that we are seeing here a positive signal for obesity surgery on yet another obesity-related complication, and this is, to my knowledge at least, the first randomized controlled clinical trial to study the effects of surgery on PCOS. which is very troublesome for many women, being one of the commonest endocrinopathies, if not the commonest endocrinopathy of women of reproductive age. And it is nice that we are now have moved away from just body mass index and weight to randomized clinical trials in diabetes, of course, that we have 13 of, and they have changed clinical practice. We've had a couple of RCTs on the effect of surgery on sleep apnea and osteoarthritis. And now we have one which is specifically focused on fertility in this cohort of women. There has been an unmet need for more effective treatments for this cohort. We have not studied yet the effects of the third generation gut hormone treatments that are gradually going to become available, and we expect a major effect size as well in PCOS. But we're hoping that by conducting this study, we will bring this more to the attention of women themselves, physicians, surgeons, and provide them a bit more confidence that this is another criterion for surgery, which we may not have seriously thought about perhaps much in the past, but it is one that from which women who have this condition, who live with this condition, stand to benefit from. So many thanks to my colleagues at Imperial, the excellent team in Coventry, the team at King's with George Dimitriadis, who has contributed to the design and execution of the study. And thank you all very much for listening.
Thank you very much, Alex, for this very interesting talk. And I think you are correct. Thank you for highlighting the polycystic ovarian syndrome issue, because these are the topics which are not widely talked, or which were not widely talked of a few years ago. And I think awareness needs to be raised. So we go to some Q&As. Before I open the Q&A box, I was going to just quickly a question. What percentage of patients with PCOS has issues with infertility?
That is a very good question, and if there are any reproductive endocrinologists in the call, they will be very likely to correct me in the percentage that I give. But depending on what you read in terms of how kind of fertility is classified, it would be about 40% of these women. And considering that this is such a prevalent condition, that is actually a pretty large number.
Yeah, and I think I agree. And that brings me to the next question, and I think it kind of follows the question here as well, that after the surgery, your trial is 1 year trial, but how soon after the surgery would you say you start seeing improvement in PCOS?
Yeah, so we are producing the slides for this as we speak. I think this is an excellent idea, which is to, we're going to do is we're going to plot the number of ovulations during the 12 months as a curve, not just before and after. But I can tell you that even I was surprised at the report. I mean, there are reports of women coming back to me to say, oh, it was almost like a switch turned on. Women that have had very troublesome regularity of their periods, and within a few months, and I'm talking about 2 to 3 months, certainly we'll start seeing the reappearance of the periods, but also almost like clockwork on the time of the month. So it was great to see that. And also just to say that even in the medical group, where we didn't see these changes, I must say that I witnessed a significant improvement in the quality of life of these women and in the way that they interact with food, because our intervention was mostly focused on eating behavior, emotional eating, stress eating, etc., rather than any form of severe caloric restriction, which is something that I am not a big fan of.
Okay, thank you. And Maureen Bushy asks a question. We are frequently asked how soon after bariatric surgery is it safe to get pregnant? So I think it comes nicely there.
Yeah,
So,
well, yeah, okay. So based on what my colleagues say, most of they would advocate approximately 18 months of waiting, which is fine if you're 25 years old or 30 years old. But I must say to you, I have seen some women that have probably left it a little bit too late. So women that are coming to us in tier 3 at the age of 38, and then I start panicking. I start to panic more than the patients themselves. So in those situations, I think we should use our judgment, and I think that 12 months is a very reasonable time point from my perspective, but at least I don't know if that is your view as well as from a surgical side, because this is when weight stability has been achieved. So waiting for 18 or 24 months, as other centers do, it would not be a good idea in the cohort of women that are presenting later to us.
thank you. I think, and that puts it very nicely to her next question as well, that many women with PCOS find great success with bariatric surgery, but after 2 years, they find that things change again and they're kind of back to before. Is this common for this to happen, or is it something patients are counseled for before?
It depends what we mean about it depends about what we mean by response. What response attempt going back to square one? I wouldn't say they go back to square one. Not to be just to say that I am following up these women in my clinics in London, because I want, outside of the trial, of course, because I want to see what happens to them in terms of the outcomes that you're referring to, but also more specifically pregnancy, even though that might be after the study. And I think most people, even people with diabetes or with other complications after surgery, yes, the honeymoon period tends to be the 1 year. But as long as the majority of weight loss is maintained, then they will still have significant improvements, I believe, and I hope, in their metabolic and reproductive, hopefully, outcomes after that. And let's not forget that now we're moving into the era where surgery is not on its own anymore. So we can complement surgery with medications, more and more effective medications, but the women that would go on the medications to enhance the effects of surgery may just have to stop them for a few weeks or so before they're trying to conceive.
Thank you. And that you touched upon pharmacotherapy, and that puts us nicely again to a question by Saima and Maureen both, saying, do you think with this new GLP-1 agonist and semaglutide and all, that would take over rather than going for bariatric surgery for problems with PCOS? Or do you think they would rather better be used, what you mentioned, together?
I think that what pharmacotherapy is now offering is more options, and I'm not, with regard to polycystic ovarian syndrome in particular, then possibly trialing with pharmacotherapy first might be an idea, or complementing the effects of surgery with pharmacotherapy could certainly be an option. But overall, we are now much more able to personalize our care. What I mean by that is, and again, if we move outside of polycystic ovarian syndrome, if our patient has got a body mass index of 60, so previously we would say to them, you're going to lose, say, 25% of your body weight for surgery, and you're going to be so much healthier, and that's wonderful. But patients are always asking for more, and if they're asking for more for health reasons, then they have got a legitimate reason to ask for more. So now we should be adding to their treatment pharmacotherapy in order to enhance the clinical benefits of treatment. So we can now take someone from 60, drop them with surgery, and drop them further with pharmacotherapy, because all the evidence so far for pharmacotherapy is that its effects are additive to the operation, which is an interesting finding in its own right.
Thank you. Before I go to the next question there, in the BAMBINI trial, I think you mentioned that you had only offered sleeve gastrectomy to all the patients, correct?
Correct.
So if you had a choice of doing that trial now, would you still do that, or would you include bypasses in them as well? And if you would include or not include, why would you not do that?
Yeah, no, I think we decided for standardization reasons to conduct an operation that most of our surgeons were comfortable with, and that was the main reason. But there's no reason why a bypass cannot be offered in these women, and who knows, it might even be superior. I'm not aware of any trials that are taking place at the moment in order to study the effects of the bypass, but I am expecting that the results will be pretty similar.
Thank you. There's another question from Josie Nicholson, and question is, given your findings, would you recommend that patients with obesity and infertility should be fast-tracked for bariatric surgery?
It depends on the age. So as we were discussing earlier on, I see this as in the same way that I would see someone with severe diabetes with complications, or someone that needs a renal transplant, or someone who needs orthopedic surgery for a knee replacement. I would consider one of the reasons to fast track women through our service in order to have surgery. And this is what we were doing. And I hope it's still happening in London at Imperial. But you know, we also have to consider the age. If the woman is 25 years old, it's, you know, I think we can wait. But if they're 38, then we have to rush. It's all age dependent.
You touched the topic of age, Alexia. How youngest do you think PCOS can start being diagnosed? Say in adolescent?
Yeah, it can start being diagnosed in adolescence.
And do you see a role as early as in adolescent with bariatric surgery or pharmacotherapy?
Yeah, not for PCOS. Yeah, I wouldn't say that PCOS is likely to be the indication in adolescence. It's much more likely to be the adolescents' metabolic health, and also there's kind of social health, which we know from very nice studies that improves very nicely and safely after surgery. So I suspect that there will be another indication for those girls to be treated in adolescence with surgery. And of course, as a result of that, polycystic ovarian syndrome is likely to improve as well. I wouldn't consider it to be the primary indication.
Okay, thank you again. I think question from Alamin Al-Kundi is something what we discussed. Is any cutoff BMI for surgery for PCOS in general? I assume the NICE guidelines or the revised IPSO
I'm afraid you have to. Yeah, I'm afraid you'll have to stick to the standard cutoff. This doesn't mean that going lower is not going to have an effect, but and of course, let's not remember that kind of 2.5 reduction in women from specific ethnic groups. But I'm afraid in order to get this funded, you'll have to stick to the rules.
Good. There is a question from Abdullah Mawas. Is the effect on PCOS from the hormonal changes or due to weight loss changes, you think, or both?
Yeah, I don't have the answer to that. We are conducting a correlation. We can only make such hypotheses from correlations, really. I don't think it will be possible to do cause and effect type of testing here. So we are currently conducting the correlations, but from the ones that I have seen so far, as with everything, I suppose, what we have learned over the last 2 decades is that weight loss is the dominant mechanism through which all of these metabolic conditions improve, including diabetes or fatty liver disease. Whether there are some weight loss independent effects, they might be there, but weight loss tends to be dominant.
Thank you. I think Ravi Krishna had similar questions. I think you already answered that. And Anna Kamoka, your colleague, she asked,
Yes.
already mentioned, she's asking about, would you have done, would you see difference in outcomes if they had gastric bypasses? I think you touched on that.
It might be. I would repeat by saying that it's like certainly the first year is likely to be similar, but possibly in the longer run it might be different.
There is a question from Rim Regia. She said she's done actually a postgraduate course in PCOS. Her topic was that, and she suggested, I think we need to study females with normal BMI and healthy lifestyle as well. And do you think there are any other solutions they do, or we could make interventions?
For women with polycystic
BMI,
ovarian syndrome and normal BMI
and healthy lifestyle.
This is a little bit like I do feel for these women. It's a little bit like people with type 2 diabetes that are on normal weight. Their options are so limited. So even if you do a lifestyle intervention, what are you going to target in those women? So this is a very difficult cohort of women to treat, and therefore our treatments should try and focus on what aspect of polycystic ovarian syndrome is affecting them. But unfortunately, we cannot use the mechanism of weight loss to help with their specific presentation, like we cannot use it in people with type 2 diabetes who are of normal weight. So even more limited options there.
Thank you. And that's is an interesting question from Maureen. This is, some of these patients have complained of hip pain post-operatively. Is it a side effect, or have you seen something, or is it a side effect of bariatric surgery, or is it something you have encountered?
Hip
pain post-op.
I don't think this is specifically related to this cohort of patients. So I think that after surgery there is a significant change in the architecture of the skeleton in terms of pressures, ligaments, fat, muscle distribution. So the whole infrastructure of the body changes, and I think that's why we see in people that we are trying to help with back pain, even that we initially may see a deterioration during the active phase of weight loss when all of these dynamic changes are taking place. And I think that when the weight loss plateaus, it is only then that we're going to see the stabilization of the system and hopefully improvement. So I think that is probably coincidental and as part of the wider restructuring of the skeleton.
Thank you. I think I agree that sounds rare or not related to the polycystic ovary or the operation. Question from me: what percentage of people, patients who would have PCOS, there is some correlation that this patient could develop endometrial cancer as well?
Oh, yes.
Yeah.
Yes.
Do you think what percentage is
I don't know the numbers. If there are any of my colleagues in the call and they know the numbers, that'll be great. But endometrial cancer is a very interesting form of cancer, uncommon though, still uncommon. So then I think that the percentage will be small. But who knows whether this type of intervention in those that are predisposed to that prevent it, but it is very difficult to study because it is uncommon, and it tends to be mostly in postmenopausal women. But in those women who are premenopausal and want to retain their fertility, some work has been done in order to avoid hormonal treatments for endometrial cancer, and of course to avoid hysterectomy. Some work has been done with surgery to show that bariatric surgery can be used almost as a cancer surgery for these women. But obviously, if you were to embark on something like that, you need to be doing it properly and managing these women very intensively and monitoring very intensively, because we don't have RCTs and you don't want the disease to escape. On the same note, we know that women with endometrial cancer also have got associated cardiometabolic dysfunction, and that's a major form of morbidity and mortality, and a similar phenomenon we're seeing in, obviously, because there's overlap with PCOS. So intervening early may change the cardiometabolic profile of these women for later on in life, but these are things that I don't think we will be able to definitively demonstrate with the study we've just done.
Yeah, and I think, as you know, for the PCOS, that would be a different age cohort as well, isn't it? PCOS would be more in the reproductive age group.
Correct.
Bring that, whereas for the endometrial cancer, that would be a bit later on.
Correct. Exactly right.
But do we know of any other additional risk factors which we could modify with that for the endometrial cancer thing? Not studied yet.
No. But again, I think things that we have learned from the SOS and other studies is that, mostly the SOS, is that the earlier you intervene in metabolic syndromes in general, I would call them metabolic syndromes, the better the longer term outcomes. So if you intervene in pre-diabetes, you're going to get a lot more out of your money later on, in terms of not only in terms of diabetes progression, but also diabetes complications. So it's interesting that the earlier you intervene, even in pre-disease states, you tend to have more of an effect on actual complications. So another reason to try and treat these women early, possibly. We're making inferences here.
Thank you. There is a comment by Professor Vinod Menon, the president himself. He says, great talk, and thank you for involving Coventry for your study. And they were careful in recruitment of the patients that had no contraindications for sleep. And I think they're pleased to report that in the last 18 months, none of the patient has had any troublesome reflux symptoms in this group of patients.
And Vinod has done a great work in driving all of this difficult process through COVID in Coventry.
Thank you. Well, the question keeps on coming, but we are reaching the finish time, so we'll have to wind up. Again, few comments from Rajat and Maureen and all saying excellent talk, and they're looking forward to your paper. Do you know when your paper is due for published, the BAMBINI one?
We're aiming for March.
Fantastic. Thank you very much. I think we need to wind up. Otherwise, there'll be another hour of Q&As, Alex. So thank you everyone for joining. I can see there were about 65 at some point, and thank you for all the Q&As. Thank you again, Professor Miras, for taking this time in the evening to give this excellent webinar, and it has been quite educational. And before we finish, I would like to highlight that the next educational webinar is on 8th of March. That is by the Chelsea and Westminster team. So do join in on that day. Following that, on the 22nd of March, there is an invited webinar, and that will be given by Mr. Matt Venus. He is a plastic surgeon, and he'll be talking of a role of plastic surgery. So thank you, everyone. Have a nice evening, and bye-bye. See you on 8th of March.
Bye-bye.
Thank you.